gastroenterology. This is the actually fourth class in the fifth series, and we started these master classes way back during the COVID times. And when we actually started, we were feeling whether it will be good or not, but it became a big hit during the COVID times. And then later on, we persisted because we actually have all very common topics which are important for practicing gastroenterologists, not only for the residents, but also for the practicing consultants, and they are being given by the excellent speakers of Indian Society of Gastroenterology. So welcome you all, and I hand over the mic to Dr. Amit Mathur, who will introduce the speakers and the topic.
Thank you, Dr. Nijavan. We have a very interesting topic and an excellent speaker, and it's a problem which everybody manages in a GI practice, that is the multidisciplinary management of cholangiocarcinoma. So we would be discussing both the types, the intrahepatic and hilar, and we have a very good speaker, an eminent speaker, Dr. Bhaskar Nandi, who is a consultant gastroenterologist, and Amrita. And without wasting time, I would request Dr. Nandi to kindly start the proceedings on this wonderful topic. Dr. Nandi, please.
Thank you, sir. Thank you, Dr. Mathur and Dr. Nijavan, for this kind introduction. Today's edition of Masterclass is on cholangiocarcinoma, its multidisciplinary management, and the importance of team management for this particular tumor. And as the name suggests, we'll be restricting ourselves to intrahepatic hilar, and the distal cholangiocarcinoma is outside the purview of today's discussion.
Yeah.
At the outset, we all agree that cholangiocarcinoma is a very difficult tumor. And there are very many reasons for it. And personally speaking, I find it very difficult mainly because of diagnostic issues. Getting a tissue sampling is very difficult. We don't have any specific tumor markers for it. We all have burnt our fingers with CA19-9 if we closely follow that. So apart from difficulty in obtaining tissue, and once you diagnose, the presentation is at such a late stage because the tumor remains silent for very many months, maybe a year also. So when it comes in the final stage, it is mostly beyond any definitive cure. And we are left with palliation, biliary drainage, and whatnot. And even if we achieve curative resection, the recurrence rates are unreasonably high. But one thing which stands out, and that's the bottom line in cholangiocarcinoma, whatever type you're dealing with, that the best chance of success lies with a multi-modality approach. And for that, I think every hospital tumor board is very essential to discuss cholangiocarcinoma, because you require inputs from the hepatologist, you require it from the intervention radiology, the oncologist, and of course the hepatobiliary surgeon. And most important, which is emerging these days, that of the pathologist, the molecular pathologist. So it's a multidisciplinary team approach for management of cholangiocarcinoma. So my flow of thought will be first couple of slides, maybe we can discuss about the classification. One thing I'd like to make clear right at the beginning is that this session is not a review on cholangiocarcinoma, because for that, you all have the text and the literature with you. My thrust and focus will be on the clinical application of what is written in that literature, that how it is applicable at the bedside to us and in our clinical decision making. So we see the importance of classification, that how it affects the tumor prognosis and our decisions. We go through the risk factors. We have a glimpse of how we see it in India. Mind you, there are a huge paucity of studies. There are hardly any studies of series of cholangiocarcinoma from our country. So how do we see it in India? And then, of course, we come to the two main topics. One is the diagnostic modalities and the therapeutic strategies. If we talk of classification, let's start with the anatomical one, and that's a basic one, just for our understanding for diagnosis and therapy later on. Now, we have three types of cholangiocarcinoma based on location. What we are discussing today is the intrahepatic cholangiocarcinoma, and by definition, these are the tumors which arise from the second order bile ducts. They are intrahepatic, they usually form a mass lesion over there. Then we are also discussing perihilar cholangiocarcinomas. Now, as per definition, perihilar will be from the insertion of the cystic duct to the second order biliary ducts. So anything involving this segment of the biliary tree can be termed as a perihilar cholangiocarcinoma. And as against the intrahepatic ones, which usually present as a mass, here we have the malignant biliary strictures as the presentation and the problem with us. And of course, the distal cholangiocarcinoma is anything which is below the cystic duct insertion, right up to the ampulla. So I think this definition we are all very familiar with. It's also very important to know for our management aspect. These are all clinical applications about the types of hilar blocks that we have, because this type of hilar block has got a direct management on our diagnosis and of course on biliary drainage and further therapy. Now, in the Bismuth classification, we have four types. Type 1 and type 2 are the a little bit simple ones. And let's say type 3 and 4 are the complex ones. Type 1 is stricture within 1 centimeter of the bifurcation. The important point to note over here is that the confluence is patent. It has got a huge impact on how we manage if the confluence is patent. In type 2, the strictures are limited to the confluence. The confluence is blocked. Type 3A and B depends on which duct the stricture has gone into, the right and the left. And of course, type 4 is bilateral secondary or tertiary branches, or these are multifocal strictures and the most difficult to treat and drain as far as gastroenterologists are concerned. Now we come to two more classifications, which is generally not discussed. One is classification based on growth pattern. I think that's very important. And of course, associated with this will be the molecular classification. If we look at the growth pattern of these tumors, there are basically three types we can classify. One is a mass-forming cholangiocarcinoma. As you can see over here, basically intrahepatic ones. These are homogeneous attenuation, irregular peripheral enhancements, and these descriptions are there. The other two types are the periductal. Now, in periductal, the growth is along a dilated or a narrowed bile duct without mass formation. And it manifests as an elongated, spiculated, or a branch-like abnormality. Basically, it follows the ducts from where it is arising. It's like a periductal infiltrating type. And then, of course, you have the intraductal. Now, it's very obvious from this description that the growth pattern of a cholangiocarcinoma is going to determine not only the clinical presentation, but diagnostic and therapeutic issues will depend on this, on what type you're having it. Now, if we look at mass forming, it is not only, it also gives you an idea, the morphology, about the tumor behavior. What has been noted very clearly is that mass forming ones are aggressive, early invasion of portal vein branches, and there is a tendency to intrahepatic mets. As we go on, you realize later that whenever you're deciding, let's say for a surgical resection, or let's say even if we are considering a liver transplantation in a particular subset of patients, intrahepatic mets is a big issue over there, because the tumors, they become late. Many times it is difficult to pick up these mets. It's only during staging or during surgery you realize that the liver is studded with satellite nodules. So mass forming cholangiocarcinomas are notorious for all this. Then the worst prognosis is with the periductal one, which we had seen, where it infiltrates along the duct. It has got an early lymphatic spread and significant spread along the proximal and distal bile duct. The problem which we face in periductal infiltrating type of tumors as gastroenterologist is what I find is taking a biopsy sample from them. Whether you do with a brush because it is periductal, or you try to see the thickening and try to do a USFN of this, it's very difficult to hit the target in periductal ones. And many a times you have to proceed with your therapy without actually getting a tissue diagnosis. And then, of course, you have the intraductal growth. Of course, this is at the earliest stage because it blocks the duct. The patient presents with jaundice and cholestasis. And this also has, sorry for the spelling mistake, this also has the best prognosis because you tend to catch them a bit early as compared to the other two. It has a lot of connotation as far as molecular profiling of the tumor is required. Now, usually as gastroenterologists, we don't think in terms of molecular profiling, but cholangiocarcinoma is a unique tumor, and a stage has arrived that we need to think about molecular profiling. Two reasons. One, most of the tumors arrive late to us and they are beyond any curative resection. You may do a biliary drainage and then it is handed over to the oncologist for targeted therapy, and in which the molecular therapies have become very important. And so getting a tissue, giving it to the pathologist for profiling becomes very important to us. Now, if you look at the intrahepatic cholangiocarcinoma, the point to be noted is that it can present in either way as a mass forming tumor, or it can present as a periductal or intraductal tumors. Now, there is a further classification over here, which we can see in the next slide, that intrahepatic can arise from small intrahepatic bile ducts, or they can arise from large intrahepatic bile ducts. This is not theory because, as we shall see, the origin determines a lot as to how the intrahepatic tumor progresses. And similarly, for extracellular, you have perihilar. Our point of discussion today is intrahepatic and perihilar. And as you see, they have got different molecular profiles, and very difficult for us to remember this since we are not dealing with it on day-to-day basis. But it's always good to have a chart with us that this is what we are looking for, because each of these targets which have now been identified, they are a therapeutic target. And if we look at the figures as how systemic therapy is helping us in this, it has made a significant difference in the overall survival. This is what I was saying, the large and the small duct variants of the intrahepatic cholangiocarcinoma. The origins are different, the risk factors are different. This is what we commonly see, and these are the risk factors: hepatolithiasis, biliary disease, Caroli's, congenital fibrosis, whereas the run-of-the-mill cirrhotic background is usually seen in the small duct intrahepatic cholangiocarcinomas. Now, fortunately, they all come as a mass formation where the diagnosis is a bit easy, but the large duct ones, which are very common, they have a variable growth as we have seen. They can be periductal, infiltrating, they can be mass forming. The molecular profiling is different. So why it is important? Again, because it has connotation for the systemic targeted therapy. So it is very important to know the origin, whether you are dealing with large and small duct. So what we have seen in the last couple of slides in classification is that getting a tissue, I think, is becoming very important, because your molecular profiling of the origin of the ducts, the tumor behavior, they all depend on pathology, on the tissue. And as I said in my first slide, getting a tissue is the main challenge in cholangiocarcinomas. These risk factors are basically known to us, and why we have separated in this is that in most of the Southeast Asian countries, it is the liver fluke which is the commonest cause of cholangiocarcinoma. And what underlies all these risk factors is two things. One, a biliary inflammation and biliary stasis. So whenever you have these two, because of whatever etiology, intense and a persistent biliary inflammation, low grade or high grade, and a biliary stasis, these are the prime reasons on which cholangiocarcinoma can develop. So I have enumerated whatever has been found. Now, if we look at the first six of them, PSC, colorectal cysts, especially type 1 and type 4, Caroli's, liver cirrhosis, and cholelithiasis, actually it is more like a hepatolithiasis. These are the established risk factors for cholangiocarcinoma. Rest all are probable. And in our country, actually, we see more of what we see in the Western countries. Liver fluke origin is most in the East Asian countries. Let's have a look at our Indian series. Now, while I was trying to review the Indian situation, what strikes you immediately is we actually don't have any significant series, much series from most of the centers. There are case reports, there are small case series. Uh, these are two articles which have a substantial numbers. One is from Kochi Amrita, that is of 137 cases of cholangiocarcinoma, and And what we have seen is a mean age of 62 years. It's in the elderly. Type 4 bismuth type of malignant stricture was a commonest. And curative resection was, sorry, and anything? The curative resection, has been the minimum. I'm sorry, am I audible to all?
Yes, sir.
The curative resection is very few cases are eligible for a curative resection. And as you can see, the 1 year mortality is very high. So it's a series of 137 patients. But I think the largest series of intrahepatic and Hiler and is from the surgical oncology unit of Tata Memorial Hospital at Mumbai. And this is the paper which they had published in 22. Now, these are 760 patients only of the varieties that we are discussing today. That is the intrahepatic cholangiocarcinoma and the perihilar cholangiocarcinoma, and 333 and 427 cases. Now, what I'd like to bring out over here is that if you read the literature, it's always said that the intrahepatic cholangiocarcinoma incidence is increasing. Now, the literature says that the commonest variety may be the extraductal and the and the perihilar, the extraductal ones, extrahepatic ones. But gradually, all over the world, it is the intrahepatic situation which is increasing. And in fact, it has more than half of the cases of cholangiocarcinoma are because of intrahepatic. But there is a catch to this data because now it has been realized that perihilar cholangiocarcinoma has got no separate ICD code. So most of them have been classified into intrahepatic cholangiocarcinoma. And what we find today is a huge increase in the amount of intrahepatic cholangiocarcinoma cases. But if you analyze each series, you realize that the majority of them have been actually perihilar cholangiocarcinomas rather than intrahepatic. Now, if you look at the Indian scenario over here, definitely perihilar is much more common than intrahepatic. 56%. And this is a real world experience also, that when we talk of cholangiocarcinoma, the malignant hilar strictures are more than the intrahepatic masses, which we confuse with SCC. So in this case, the presentation, of course, is this. And what I like to highlight in their series is that if we divide cholangiocarcinoma into localized, locally advanced, and metastatic, you see over here that perihilar generally has a localized presentation more, and mainly because of the presentation as obstructive jaundice. So they have been caught early in the disease stage. But when you talk of intrahepatic, in which you just have a mass or a multifocal mass in the liver with no biliary significant involvement, once it comes out, the presentation metastatic is the commonest. More than about two-thirds of cases, they come to you when the disease has already metastasized and you're not able to offer any definitive cure. So that's a huge difference between perihilar and intrahepatic about when they present in the natural course of disease. If you look at perihilar and you look at the type of blocks, again, the advanced blocks take the majority, and it shows that disease is presenting at a later stage, or it is where the cholangiocarcinoma builds up, type 3 and type 4 within the intrahepatic ducts. And the relatively simple ones, type 1 and 2, they are in a minority. Curative resection, abysmally low, hardly 2 digits, 14.5% and 10% in Tata Memorial Hospital series of 700 patients, where actually these patients would go into a curative treatment. So I think this slide of these two studies tells us a lot about cholangiocarcinoma, their presentation, the complexity of the problem, and how little we can offer them a curative treatment in such tumors. Now, coming to the main elements of our discussion today, one is diagnosis and the other will be therapeutics. As far as diagnosis is concerned, let's all think what we do in our own units. Obviously, imaging, endoscopy, tumor markers. These are the main first three steps that we do whenever we suspect malignant hilar stricture or a cholangiocarcinoma intrahepatic. Then we try to take a biopsy. There are various modes of it. And of course, what do we do with the tissue to get a diagnosis? So these are the diagnostic modalities that we have. Now, if we talk of when we have a patient in which we are suspecting this, I think important to know a couple of points. One, CT scan is important, and CT of the chest and abdomen, both of them are important for the initial assessment of cholangiocarcinomas. That is one. Secondly, PET CT is not a must. The routine use of PET CT in pre-operative setting has not been established in prospective trials, and this decision has to be taken in case-to-case basis. Now, if we further have a look at the intrahepatic and extrahepatic cholangiocarcinomas, EUS or ERCP may be helpful in the setting of bile duct dilatation if no mass is seen on CT or MRI. But the important principle is before you attempt your EUS or ERCP, it is very important to construct and get a good biliary roadmap. So in that case, a contrast enhanced MR and MRCP is preferred for evaluating the extent of a biliary tract involvement. So I think a couple of messages, the general principles say that CT, MR are both required. CT, MR, especially if you are suspecting a ductal, intraductal or periductal hilar cholangiocarcinomas. Contrast enhanced MR is more useful. PET CT is not a routine, it has to be on a case to case basis. And of course, when you're looking for intrahepatic and if you want to differentiate it from HCC, your delayed phase imagings are very important. So when you plan your CT protocol, it has to be as for that. Now, this is a table which we can always refer to as to what are the different image USG, CT, and MR, and the characteristics of intrahepatic and perihilar. And as we see that mostly we use a CT scan for this. It's a hypodense lesion, and there is a capsular retraction is highlighted a lot as if it's a pathognomic for cholangiocarcinoma, but you realize that it's present in less than third of cases. So there are many cases in which you do not have a capsular retraction. But most important will be, as we shall see in the next slide, is how it enhances and doesn't wash out on triple phase CT scans. MR will be very important, especially for the perihilar one. And again, the importance of contrast in MR becomes very important because these are best visualized on delayed imaging, obtained about 5 minutes after a contrast administration. So I think these are the subtle points which we can discuss with our radiology colleagues, and this is how the unit builds up for a better diagnosis of cholangiocarcinomas. These are very familiar diagrams, and for ease of understanding, I have taken it from radiology rather than putting up real life patients' images. This is very common. Like in HCC, we expect arterial enhancement and, of course, a rapid washout in the portal venous and delayed phases. Whereas in cholangiocarcinoma, we have got an arterial phase enhancement. The rim shows over here as it goes over there. And as you go on to the delayed images, there is centripetal filling of this and it actually enhances. One important point they have given over here is that if you look at this delayed image, there is a centripetal enhancement and it is encasing a branch of the portal vein over here. In HCC, this is the point which has been highlighted that this tumor encases it, whereas in HCC, it would have gone as a tumor thrombus inside this. And apparently, this is one of the differentiating points between cholangiocarcinoma and hepatocellular carcinoma. If we talk of periductal, you can see over here this how the duct is thickened. And as we shall see later, I think what we look for is how to differentiate it from a benign stricture. That becomes very important. There are a couple of points which we shall see. Over here, we like to highlight that it is asymmetrical thickening over here we have. This is quite irregular also we have, and this is quite a little bit of a long segment. I think these are all points which will help us. There are soft points, no doubt, but they help us in trying to differentiate between a benign and a malignant health structure. And similarly, these are, of course, the precursor lesions where you have a lot of mucin secretion and it forms a mural nodule. They again are there in the hilar cholangiocarcinomas. This is the CT picture in which you can see this mucin. And then, of course, these are the MR pictures for this. This is differentiating from HCC, won't spend much time. I think the diagrams are very obvious and we do it on day-to-day practice, but it still requires a good sort of collaboration with our radiology colleagues to read the CTs and understand the differentiation. Because the question it brings out is that it's not that if you have got a doubt, you put in a needle and see whether it's a cholangio or HCC or maybe a fusion in minority of cases. The question of uh, is of tumor seeding. Is it a really a clinical problem with us, or it is just overrated with only very few cases? I think I'm not still very clear on this even after review, that what is the clinical impact of the prospect of tumor seeding when we take a biopsy, especially in those cases we are looking for a curative resection or a liver transplant. Now, I was alluding to how do we differentiate between benign and a malignant stricture. So these are two tables that I have tabulated. One is on CT scan, the other is on MRI. These are all practical problems bedside, as I had promised earlier, that we'll be only talking about the clinical applications and not theoretical stuff. Now, if we come to CECT, what helps us is mass lesion and nodal involvement. Of course, nodes more than 1 centimeter. And whether the lobe is, the affected lobe is atrophied, the other one is hypertrophied. This atrophy hypertrophy complex in imaging, it can be present in benign also. So it actually is not a differentiating point. So on a CT scan, we look for nodal involvement. That's what we do, because the nodes are a big giveaway. And secondly, they can also point out from where maybe instead of the mass, you hit the lymph node for a biopsy. Coming to the MRCP, because MRCP is very important in this, and as I said, we contrast MR is much more beneficial. Now, these have been validated in multivariate analysis that presence of a mass lesion, an irregular margin, asymmetric lesion, and a length of the stricture more than 1 centimeter, they are actually, as we see the p-values, they are the important indicators of a malignant as against a benign stricture. Whereas an abrupt cutoff can be seen equally in the benign strictures as well. So this, suppose you see a signal void and abrupt cutoff, it doesn't mean a malignancy. In fact, the other points are more important. Asymmetric lesion, irregular margins, and the length of the stricture. If you look at the lab, and this is a study from PGI Chandigarh, and what they have found, 3 lab parameters along with the imaging, which I have shown above. Bilirubin of 8, more than 8, alkaline phosphatase more than 470, and a CA99 more than 100. They had gone more in favor of a malignant stricture. So I think this problem which we face day to day, benign versus malignant stricture, we can keep these parameters in mind in trying to arrive at a strong suspicion. The imaging pictures and of course this lab parameters. Diagnosis, now let's come to endoscopy. This is the first modality as gastroenterologists. This is how we pick up most of our cases of malignant stricture. Based on our Bismuth classification, this is how the cholangiogram picture looks. Now, we try to keep in mind what we have learned in the previous slide as to what can be benign and what can be malignant. And we can also keep the Bismuth classification at hand to correlate with our cholangiogram picture. That helps to actually find out the type of classification also. But I think there are a couple of issues in ERCP which I'll like to raise over here. And I'm sure Dr. Mathur also will have an opinion on this. The problem which I find is, one, if I'm suspecting a hilar stricture and I don't know about whether the intrahepatic there are more strictures, multifocal strictures, what do we do with the contrast? Now, am I exposing myself to more of cholangitis because maybe in the end I will not be able to drain all the pockets which are obstructed? So do I, in my first ERCP, if I don't put a contrast, I also can't delineate and find out whether it's a benign or malignant. So what sort of a compromise or dilemma is this, that do we use a contrast? Because I have seen that even if you are using an air contrast, even that is good enough for ascending cholangitis, because it's not only even air can transport the bacteria over there. And secondly, if I am trying to put in a stent, one is you put a stent without a contrast and aspirate the bile and see that yes, it has reached a pocket where it is draining something. But that may not be accurate. So it's very important that we construct the biliary roadmap based on imaging first before we attempt any invasive. So we exactly know which system our guide wire needs to go in first. So I think these are the two problems about contrast to use, not to use, or even if I use, any precautions I can take on that.
Yeah,
And
can I intervene here?
yes, sir.
We had a discussion in a recent workshop with Dr. Nageshwar Reddy on this aspect of an air cholangiogram versus a contrast. In fact, we at our center also use an air cholangiogram to avoid cholangitis, and it definitely we find it more useful. But he was of the opinion that a contrast cholangiogram is always better, and it delineates the involvement of the segments better, and they don't do an air cholangiogram. So that was his point of view. But
So I think, sir, like in most cases in cholangiocarcinoma, the bottom line is it depends on the unit experience.
yeah, I think that's it. I mean,
But definitely putting in the contrast has got its own advantages. We delineate, we characterize, we know how to step in later for drainage. But I'm really scared about cholangitis aspect of it. Though I'm using contrast, but
we feel more safe with an air cholangiogram.
air cholangiogram. So I think it will be a good thing to study this aspect further, sir, and see what we all should follow. And the second problem comes in after you have done the ERCP and taken some tissue as to how do we diagnose it. Now, the commonest is we do a brush cytology. Now, bile aspiration, we all know it doesn't help much, but does brush cytology help to us? If we look at the figures, its sensitivity is just 20 to 40%. Let's say in 1/3 of cases, if you get a positive, yes, specificity is 100%. But if you look at sensitivity, it's very poor for brush cytology. But come to think of it, this is the commonest modality that we do when we are suspecting a malignant stricture. So then the question comes of passes. Now the literature says 30 passes. I don't think practically, or maybe I'm not doing, but are the other centers doing 30 passes in brush cytology? I doubt. What we all do is basically 5 to 6 passes, maybe a little bit more than that. But even with 30 passes, you see the sensitivity increases to around 50% from your 30% otherwise. So, is it worth trying or not? That's the second question we will like to know in discussion. And third,
I think, but again, its limitation is it is not there in all the centers. But a cholangioscopy would be give a better yield as compared to a breast cytology and biopsy.
Yes, I'll come to that. So, and of course, the second question is, do we dilate the strictures before doing the breast cytology? Well, the literature says that it does not improve the yield much. Both are around 30%. So it is not that you dilate and then do it. You can do it otherwise also. So the question remains, we do breast cytology hoping for that 1/3 of cases where it can give us a definite diagnosis. If we take more passes, that is good. But what I have seen and I faced also post ERCP pancreatitis after taking a lot of passes from breast cytology. So those are, I'm sorry, yeah. Then there is intraductal biopsy forceps, which I find is very difficult. Either we can, I think the mean is to the baby scope or the thin scopes we go in, but we have not done this. And once we get the tissue, we put it for fish studies. And our hospital still yet doesn't do fish. They're planning to start all this. So, but where it is done, I think it has got a very high sensitivity specificity. And of course, you do next gen sequencing for cytology, and that is a very high sensitivity. So both these two, you require a very good molecular lab and a pathology department with you. And I'm sure at least many centers in our country do not have this facility as of yet. So ERCP, very handy, the first modality that we gastroenterologists use, but it comes with its own problems. Now, what Sir was just mentioning about cholangioscopy, now most of the units nowadays, we have our single operator cholangioscopes. And as you can see that this one is from a patient with periductal and this is from intraductal. My own picture that I always visualize is that it's a very dirty looking mucosa that you can make out as you enter the hilar near that. Sometimes loose tissues are there, a lot of mucus debris are there. It's thickened, it's a stricture, you will not be able to cross it. And of course, it's very intensely red. So these are the findings that we have found in cholangioscopy. And this is a systematic review, 2015 GI endoscopy, 10 studies and 456 patients. And they have found a very good sensitivity, as Dr. Mathur was saying, and specificity for cholangioscopy guided biopsies in the diagnosis. But one thing I like to say is that maybe in a very high volume centers where they are using cholangioscope, fine. In other centers, sometimes it does become difficult in taking a cholangioscopy biopsy, because especially if you are not able to enter the stricture segment, and just from the periphery you try to take those tissues and see. But then nevertheless, it is definitely much better than a breast cytology. And more important than that, it gives you a visual diagnosis also. I think that's also very important.
Agree.
And then, and and then to add more to the problem, we have EOS now, which has come up almost in every center. Now, endoscopic ultrasonography has been a big booster as far as cholangiocarcinoma is concerned, because it facilitates staging and it also determines resectability. So these are the two important things with which we are worried when we see cholangiocarcinoma. One, it's on tumor detection. Second, it alienates better about vascular involvement. And most important, what I have found is that lymph nodal involvement. Now, there are certain characteristics in US which we always remember. A malignant lymph node is suggested by the size, preferably more than one, a very round, homogeneous hypoechoic shape with well-defined margins, as against a reactive lymph node, which usually give a very heterogeneous echo. They may be smaller in size. And so this differentiation is important because, as we shall see later, EUS has made a big clinical impact on resectability of cholangiocarcinomas. And second is advantage that EOS has fared much better than the alternative imaging modalities like CT and MR in detecting vascular and nodal involvement. So I think this makes all the difference as far as managing cholangiocarcinoma is concerned, that if you can stage it accurately. So here's the first advantage. It is superior to CT and MR. Second is it correctly identifies unresectable disease in 83% of patients. Very important for all of us. If I know that this is unresectable, I straight away go over to my palliative chemo, targeted therapies, and drainage, rather than trying for a surgical resection. It correctly diagnosed 97% resectable. So its diagnosis of unresectable and resectable disease has made a huge impact in cholangiocarcinoma. And obviously, USFN appears to be much better in clinical decision making for CCA, for cholangiocarcinoma in most of the cases, in 79% of the time. A good sensitivity and specificity in getting the tissue. So I think US, a center with skilled endoscopists doing US, has made a lot of difference in cholangiocarcinoma management. Now, the next two slides, I show the table about EOS and how it has impacted. This one, there are about 5 good studies which show that EOS-FN, the sensitivity and specificity, of course, specificity is 100%, even the sensitivity is so high, EOS accrued FNAs. And but the point of caution is that if you look at the negative predictive value, it's still in many series 67, 57%. In one, it has become so low, 29%. So the point is that if you are getting a positive, it's fine. But if you're getting a negative, there will be still a good subset of patients who will have to undergo further evaluation before you confidently rule in or rule out cholangiocarcinoma. That even with EOS, if you get a negative value, so that still remains a concern. If you look at the clinical impact, as I was saying, that in almost more than 80% of the cases, the EOS could correctly identify a resectable disease. And it was more accurate than CT scan in determining the unresectability status. So I think once we combine our CT, MR, and then of course we have our EOS picture with us, it's a huge force multiplier as far as staging and further treatment of cholangiocarcinoma is concerned. The drawbacks in US is that the learning curve is steep. You require high volume centers where it can be done accurately. And of course, for taking a USFN, you need to be quite skilled at it. What difficulty which I find is, let's say, the intraductal, periductal ones. sometimes the wall is so diffusely infiltrated that you can't hit the needle. I'm sure Dr. Mathur can share on this much more. I'm
Tissue sampling is very difficult.
and sometimes, suppose my needle is arriving from a particular angle, and it is the other wall in which you have the asymmetric thickening. So is it always okay to go through the duct to hit that wall? Because at many places, many centers, entering the duct is, of course, not recommended. So I don't know about these practical points. Need some more input on this. That whether it is safe to traverse through the duct to hit the other wall, and or what happens if my needle goes into the duct? Does it spread the malignancy, or do I cause
We don't have too much of literature, but people they don't advise going across the duct. But the
So-
yield again is very, very poor. You need really good technical expertise to pick up cholangio-CA, especially in these periductal cholangio-CAs.
So as far as highlighted, I think with lots of advantages of EOS, but practically when we start doing it, we realize that the learning curve is quite steep, and you really require a high volume center for properly using EOS. And so that remains, that's for us to actually develop. As we enter the difficult aspects as far as gastroenterologist is concerned. Usually, we shut our minds after diagnosing and doing the biliary drainage, but then molecular testing in the tissue sample that we have taken has become very important. And I'll just highlight these 3 points that most of the studies now are on fibroblast growth factor receptors, the isocitrate dehydrogenase, and the HER2 receptors, the epidermal growth factor receptors. So these are the 3 targets which have really come up in molecular profiling, and you have immunotherapy, you have drugs to do the targeted therapy in them. So now, like a CA breast, for even cholangiocarcinoma, it has become very important to know whether it's a HER2 positive or a HER2 negative. So that's recent advances. Good to remember this table, TNM classification for any malignancy. Difficult to, it's always better to keep it handy. Attention for both intrahepatic and periductal is the T2, where you draw the line. Because once you hit T2 and beyond, you require adjunct chemotherapies if you're talking of surgical resections. So that is both for intrahepatic and that is for perihilar also. That once you stage a tumor as T2, it is always resectable but T2. Then you do an extended hepatectomy, but after that it has to be followed up with a chemotherapy. Now coming on to the therapeutics, this is the last part of our talk. Maybe another 10 minutes.
Can we take some questions? We, in fact, we on the chat box, we only have a single question where we have been asked, how do we clinically differentiate hilar versus distal block? We really didn't take up the clinical profile too much. But you want to take that question now regarding that? So,
See, as far as
yeah.
as
Go
far
ahead.
clinical is concerned, so like one, they present as a case of obstructive jaundice. Now, if we look at the clinical presentation, if we have a distal block, we might see a GB lump which is palpable. But if you are, I'm sure what the questioner wants to know is any difference in presentation. For example, as far as abdominal pain is concerned, prevalence of cholangitis is concerned, or the degree of jaundice is concerned. I don't think there is any difference in all this. I think what can differentiate us is maybe in clinical findings. This GB lump is one. It's the same difference that we find. Let's say if we are looking at a case of periampullary carcinoma, and all distal blocks, they come like that. As far as pain is concerned, it is there in both cholangiocarcinomas. It can be there. The jaundice level will not differentiate us. So I think whenever we subtract obstructive jaundice, I think the first thing we do is an ultrasound, and then ultrasound, it becomes very clear to us that if you have a fully dilated upstream biliary dilatation, the block, it's lower down and then up. And then, of course, it is
clinically very difficult to differentiate between a a distal and a hilar, excepting for a palpable gallbladder. Otherwise, pain, fever, and cholangitis, we don't really have too much of a difference according to the site of the cholangiocarcinoma.
Absolutely, sir. And as far as it's good to for academics and good for a clinical bedside differential diagnosis, but as far as management is concerned, I think we will still all go to the imaging and try to formulate a treatment based on that.
So one thing we wanted to make clear after the diagnosis is very commonly asked by the DM residents is once they are strongly clinically suspecting a cholangioCA and you have something on an vis-a-vis high resolution contrast CT, vis-a-vis EUS.
Sir, I think we lost your voice in between, sir.
Oh, can you hear me now?
Yes, yes.
So, I mean, which is the modality of choice for them now? High resolution contrast CT, vis-a-vis MRI and MRCP, or an EUS? What would they be doing, or all the three?
So this is what we have discussed, that if basically we are going more in favor of an intrahepatic, then a high resolution CT is much beneficial because it also gives a lot of ideas about the nodal and the vascular involvement.
Okay.
But whenever we see a biliary tract involvement, I think contrast MR also becomes very important. EOS has become very handy for further staging and determining resectability. So I think the last statement that you gave, I think all three are important in their own way. They are not substituting each other. Basically, all the three modalities are complementing.
So that's the carry-on message for the diagnosis.
Absolutely, sir. Absolutely.
We move ahead.
So we just go for therapeutic options. Now, this is the essence of today's discussion, I think, multimodality treatment. And this slide is just to show us that what sort of complexities we have waded into. We have surgical, we have chemo, we have radiation, we have targeted immuno. And then, of course, we have a lot of local regional therapies like we use in HCC, like TACE and radiofrequency ablations. And a lot of photodynamic therapies have come in intraductal. I have not done this or seen this at all. It's all theoretical for me. But all these other modalities, I think, are present in most of the centers and they are being used. So this is just to give an overview as to the modalities that are at hand for us to make a difference in the patient's survival. And I again reiterate what I said in my first slide, that you require a tumor board, you require a team to actually formulate a treatment for this. Now, again, we go back to the Tata Memorial Hospital study, clinical surgical oncology. Now, if we look at how they have treated their 722 patients for which the data has been published, majority have been either on no treatment or palliative chemo. As you can see the percentages over here. If we look at surgery, curative, with at least the intention to cure surgery, it's hardly 28%, one third. Whether with or without or chemo, biliary drainage or neoadjuvant chemo. So basically surgery has been just in a minority of patients. Rest all have gone into palliative chemo. And you will also realize that so much of work, literature, publications, and so much of effort of ours goes in just for this 28 to 30% cases, because this still gives the best opportunity for survival, overall survival. That if we can find that small subset of patients who can undergo a definitive surgery or who can go for a transplant. Principles of surgery, hepatic resection with negative margins is the goal, that is R0 resection. Yes, a preoperative biopsy is not always necessary. I think these are some of the few tumors which are exempted from biopsy even by the oncologist. Otherwise, they always insist on a tissue. But this narrative is changing very fast because of molecular profiling. I may not require a biopsy for my surgical planning, but then maybe I will require it if it is unresectable, then it becomes almost a must because of the targeted therapies which have come up. But this comes up because what we had said, in many cases, it's very, very difficult to get a tissue to get a conclusive diagnosis. What is important to know is what are the contraindications to surgery, because as a gastroenterologist, we should be aware which cases can be handed over to the hepatobiliary surgeon. A metastatic disease, reason is very clear: type 4 hilar duct involvement, bilateral or contralateral vascular involvement, multiple level obstructions, multifocal, especially if they are underlying PSC. So these have become as contraindications to surgery. Lymph nodal spread beyond porta hepatis contraindicate resection. So if you have few nodes in the porta hepatis, that is not a contraindication. But once you cross that, or if the porta hepatis is heavily, densely nodal spread is there, that's a different issue. But a thumb rule is porta hepatis is still in the resectable range. Multifocal liver disease is a contraindication because it is taken as a metastatic one. And during surgery, if you find peritoneal disease, metastatic, positive paraaortic nodes on frozen section, on vascular involvement, portal vein not amenable for reconstruction, these are per operative. You find out that you cannot go for a curative resection. You just close or do a palliation and come out. So this paragraph, I think, is important to know that which are the cases we cannot send them for surgery. And then comes another issue. I think Dr. Mathur will also help us in this, that what is the preoperative biliary drainage. Now, different units follow different principles. We have seen units who insist on a preoperative biliary drainage before they take up for anything. I'm not only talking of chemotherapy, even for surgery. And then there are units, majority of them, surgeons don't feel good if you have placed a stent in them because they feel that the stent creates a lot of inflammation, low-grade inflammation throughout. And per operatively, it makes them difficult to stage the tumor as to what is the involvement. So this is what they've shared with us. So they just hate if you have placed a stent over there. So
I
if
absolutely agree. Most of the surgeons don't really want a stent to be put.
so
Yeah.
if,
Yeah, go ahead. Go ahead.
so if you think that this is a resectable disease, please discuss with your surgeon before our first reflex as an endoscopist is diagnose, place a stent, and come out and then start discussing. So I think they don't like a stent, but there are certain situations where a preoperative biliary drainage is recommended. And this is what I found in the literature. It all depends on the future liver remnant. If you're planning a resection, you need to do a CT volumetry like we do in liver transplantation. And when you decide the plan of resection, whether it is anatomical or non-anatomical, you try to find out how much of liver will be left. Now, if it is less than what you want, it has been seen that if your bilirubin levels are normal, it helps in the post-op recovery. So they have come out with these yardsticks that if FLR is less than 30%, or if there is a frank cholangitis, intractable pruritus, or hyperbilirubinemia-induced malnutrition, and of course, if there is renal insufficiency, then it is better to do a preoperative biliary drainage. PBD is also important if you are planning a neoadjuvant chemotherapy, and of course, if the surgery is not immediate. So I think it still requires a lot of discussion that in which cases it is not a must. So that is the one clear message. It's better to discuss as a team whether it is required or not. This is a chart which I have not taken from anywhere. I've just made it based on our experience in the unit. Now, for example, if I have a case of cholangiocarcinoma with me, and I first assess whether it is eligible for a curative surgery or not. Remember that only a minority of them will be eligible. So how do I assess that? One, of course, we see the stage, the tumor. That goes without saying. But then other points are important. Medically fit for surgery or not. There may be so many reasons, comorbidities in which you cannot do it. Then we calculate the future liver remnant. Do we do a portal vein embolization to increase the future liver remnant? Now, if it is a normal liver, if it is less than 25%, we do it. If it is a cirrhotic liver, if it is less than 40%, we do it. So you embolize the portal vein so that the non-resectable lobe hypertrophies. So you wait 4 weeks after that and then reassess and stage the disease. And of course, preoperative biliary drainage, we have discussed when it is to be done or not. So that always remains an issue. So all these factors will be important. And then if it is a localized disease, it can go for surgery. But if it is a local metastatic, it cannot go for surgery. If it is a locally advanced but unresectable, maybe we can try downstaging these days. And this downstaging is when we start giving neoadjuvant chemo radiotherapy to this. And of course, if it is resectable, you see the margins R0 or R1, T2 and beyond, as it is, will require a chemotherapy. R1 resections again will require a chemotherapy. So in a nutshell, this is how we go. Suppose we are able to do a surgery, Then also we look at the survival and recurrence. And this is the reason why even if they go for a curative resection, following surgery also too many questions are left. Survival not very great, 5 years. Mean survival has been 1 year, and recurrence rates even with an R0 resections are over 50% within 1 year. Very high recurrence rate. So it always shows that there is some amount of metastatic or multifocal liver involvement, and which we are not able to pick up when we are doing a preoperative staging. And similarly, in a perihilar cholangiocarcinomas, I don't think there is much difference. The survival and the recurrent rates are very high in this. Now, if you get a recurrence, what do you do? Aggressive centers are planning repeat hepatectomy. We no, I don't think we are that aggressive, or in any case, the cases are so few that we cannot do any draw any inference from there. But repeat hepatectomy has been done worldwide. Lot of literature on this. But then, of course, in a repeat disease, you are left with palliative therapy in the form of systemic therapies, TACE, or local regional therapies like we do in HCC. So, in a nutshell, this is how we try to look at the surgical cases when we have a cholangiocarcinoma. Now, the question asked is that what is the role of liver transplantation today in cholangiocarcinoma? Now, one statement, cholangiocarcinoma, liver transplantation in cholangiocarcinoma is a viable option. But so far, standard recommendations are for hilar and not for intrahepatic. There are riders to that, but basically what has popularized hilar cholangiocarcinoma liver transplantation is the Mayo Protocol. The word of caution is that it's a very complex protocol wherein after staging, you take up for EBRT brachytherapy, follow it up with a chemotherapy, and then again do a staging by even an exploratory laparotomy, and then take a call based on this inclusion and exclusion criteria as to whether you can take it for a transplant or not. Once you take up for a transplant, I think even for non-cholangiocarcinoma incidents, the survival is almost similar. If the small subgroup of patients, though recurrence rates are very much there, about 14%. The problem with Mayo Protocol is very few centers are able to follow the Mayo Protocol, and in fact, hardly any. And secondly, these fantastic results, at least in our country, has not been replicated. Of course, this is to the best of my knowledge. Dr. Mathur and other experts might have a different opinion on this. But liver transplantation, Mayo Protocol for hilar cholangiocarcinomas, yes, it's an option, good results, but can we follow this always remains an issue. Now, this is again a few studies in which they have done liver transplantation. And as you can see, the outcomes are pretty much decent as any other cases. And 5-year survival, 68%, 10 years, 60%. This is from the Mayo. And this is from 12 centers in USA in which they followed the Mayo protocol, basically giving neoadjuvant chemoradiotherapy, and then had taken them up for liver transplantation. 214 cases, and what they found, a 5-year survival of around 53%. So the point is not this. The point is, and this debate has come up hugely in the West, that so-called resectable cases in which you are trying to do an R0 resection, what if we do a liver transplantation in them? If we compare the liver transplantation data, of course, which is within the so-called Milan criteria roughly, and you look at the surgical data, you find the transplantation people have done much better as far as overall survival and recurrence is concerned. So, but then of course, this is a question as of today that if a patient can afford, and if we have a donor or if we have a program, see, because whenever you talk of transplantation, the problem comes up because outside it's all disease donor liver transplantation. So in the UNOS category, do you get your plus points if you have got a cholangiocarcinoma? So it all depends on that. But suppose in our Indian setting, we have live related transplantation. Now we have a patient, and if we leave aside the cost issues, you have a resection and you have a liver transplantation for a resectable disease. Or if it is an underlying cirrhosis, the decision is maybe a little bit easier. But in a non-cirrhotic cholangiocarcinoma, we don't know. But then it's a question which needs an answer.
Agree.
And Now we come where we are bread and butter to the gastroenterologist, principles of biliary drainage. This is as part of our therapeutic algorithm. Nisha, we have around 5-10 minutes. 5 minutes. So we have 5 minutes.
Yes, we have enough time.
So if we talk of principles of biliary drainage,
Yeah.
sir,
That is the most important and relevant issue.
this is where we come in actually, sir. And adequacy of biliary drainage, one. Now that is, there are a couple of questions in this. I've raised 4 in this particular slide. That what is an adequate biliary drainage when we are talking of a hilar block, hilar stricture? Draining 33% of the liver should suffice in patients with preserved liver function. Draining over 50% was needed in patients with impaired liver function. And survival benefit was, however, when we are draining over 50% in malignant hilar obstructions, MHO. Draining 71% is the optimal volume of liver to be drained for adequate chemotherapy to be given in patients with malignant hilar obstruction. I've not given references to this because these are mostly not based from studies, but more from expert opinions. And do we agree with this? Generally, I think yes, this is what we gain. But then this brings us to the next question, that is unilateral drainage or bilateral drainage is essential in all? Of course, depending on the block. Is plastic stent versus SIMS? Or which are the best modalities to achieve this? ERCP, EUS, or a PTPT? I think these are the day-to-day questions at the bedside which always bother us as to how to proceed next once we have diagnosed a malignant hilar obstruction. Sir, any inputs from?
I think the most important is a good roadmap. I mean, a good radiology, a good MRCP is always required prior to planning for a biliary drainage. Because what is happening is we need to know the extent of involvement of the cholangiocarcinoma, whether it's a bilateral or this thing. And we, in our practice, we tend to drain both. But if there is even a hilar involvement with a slight suspicion of involvement of one of the ducts, we tend to drain. But again, the most important thing is a good radiological mapping of the disease, which is important. And I strongly am against putting in a plastic stent, because we have always burnt our fingers by putting in a plastic stent, and it is always advisable to do a SIMS or a PTPT. That is what is our take on the adequate biliary drainage.
So, totally agree with you, and that's what most of the literature also points at. That, but I have a question in this. For example, when the first patient comes to us and we diagnose a stricture, and probably that is malignant, I've taken my brush and all. So in my first sitting, what do I do? Do we put a plastic stent then only? Because if I place a SIMS and the disease appears to be resectable, what happens? Or what should we follow in all this?
Honestly, if you see that we are, in majority of the centers, we are not really emphasizing on the histopathology and the breast cytology. There is other clinical evidence which strongly give a suspicion of malignancy. So there are very few centers who will first take a breast cytology, wait, and then put in a SIMS. But in majority of the centers, it is always, there are other modalities which are strongly suggesting a cholangio CA, and then you straight away put in a metallic stent. But if this practice is there for putting in a plastic stent and then going in for a metallic stent, I think the incidence of cholangitis or the increasing of morbidity.
Sometimes what happens is, this is also another thought that if I place a plastic stent and till I'm evaluating whether it is resectable, non-resectable and all those issues, but my advantage is the plastic stent will tell us whether we are draining the correct system, and it decompresses. And then of course in that same system we place our metal stent, and obviously it is effective. So we don't waste.
But if we have got a good radiological mapping of disease, so I think we are reasonably safe to put in a metallic stent.
So I think we come to that point which we discussed earlier in our talk, that before you intervene, it's very, very important to get a good biliary roadmap And for that, whatever is required to you, do a good contrast resolution CT, you get a good MR, sit with the radiology and build your biliary roadmap. And then you decide what needs to be trained and when your stent needs to be placed. I think that will solve a lot of issues of these questions.
Practically, if you see the resectability, the cases in our country, the resectability and the patients who would be resected would be the 30 to 40%, which has been quoted in literature. So I don't know what is your personal experience, but the number of patients going in for surgery in our country is very less in patients of cholangiocarcinoma. But they already have a majority of them have an unresectable disease.
Sometimes actually, sir, you get, complacent on this, that I always feel like in our center also, I know that this will be unresectable. So go in for a metal stent and drain it. But sometimes it also scares you that we never also bring into our account that, do I look for resectability,
Yes.
So many cases every day we are seeing which is unresectable. The resectable part is always out of your mind most of the time.
I think the carry home message is that we need to further evaluate whether they are resectable or not, and then go in for a biliary drainage.
So a good imaging and a sitting session with the radiology, I think, is imperative, sir, in this.
Perfect. So it has approach.
This is a busy slide mainly to show the debate between unilateral or bilateral. Now, if you look at these three studies, and they are pretty recent, one of them, the systematic review and meta-analysis, unilateral versus bilateral, and somehow they said that in unresectable malignant, they said that there is no difference as far as successful drainage is concerned, whether you put in one or two. So this was there. All of us generally believe that you use a metal stent and maybe you drain both the systems. That's what I follow. On many centers may differ on this. But unilateral versus bilateral, it is the same successful drainage. If you look at the older studies, they have also found the same. But if you look at a very large studies, multi-center trial between malignant hilar obstruction, recently published, and they have come out with certain figures that bilateral metal stent placement was better than unilateral as far as patency of the stent, re-intervention, and overall survival is concerned. I think it's a very strong data what they have given. Second is metal stents were always better than plastic with respect to clinical success. Now, if you look at the percentages, even a unilateral metal, they have said is much better than a bilateral plastic as far as clinical success is concerned. 83 and 71. I don't know whether they are significantly different or not. So what the question still remains and will be very interesting to know from very many centers as to what do they follow. Do they place a metal stent right at the first go, and secondly, one system or two systems, and how much they are against a plastic stent? This will be interesting to know, especially our Indian data, if it gets published and come out on this.
Yeah. But practically, it seems that if we have an option, it would be always the best would be a bilateral metal stent.
Bilateral metal stent, yes, sir.
Well, it's an unresectable disease. Although we have not really evaluated the resectability, but we usually assume it's an unresectable disease. So
yes.
it is.
But of course, this study, we need to look at the systemic.
Yeah. The literature says otherwise.
Otherwise,
it looks like if it is possible, and if we have the technical expertise, a bilateral would definitely be better than a unilateral drainage.
So now the question comes, ERCP versus PTBD, ERCP, and then the latest entry, US biliary drainage versus PTBD. Is there any way to decide which one to go ahead? Just to summarize, I know very many centers that if it is type 1, you are still doing by ERCP, but anything more than type 1, especially if it is type 3 and 4, you don't even attempt and you straight away go for PTBD. So this has been the practice from where I've got trained also. But then if we look at these studies, now this table actually compares ERCP with PTBD, ERCP biliary drainage and percutaneous PTBD drainage. All the four, there are all systematic reviews, and all of them have found that somehow PTBD was better than endoscopic drainage. Now, the catch is that these are heterogeneous group as far as your level of biliary stricture is concerned. So there are minority of type 1, but majority have been type 3 and 4. So if it is that, it is understood why PTBD has come much better than endoscopic drainage, because obviously if you're talking of type 3, 4, I think it's that. What I like to know, Dr. Mathur is here, that
Mhm.
if I have a type 3 and 4, do I even think of endoscopic like we have been doing, we have done, but or is it straight away just involve the radiology and go for a PTBD?
I mean that's a pretty tricky question. But in type 3, if you have a good road mapping and if we feel that we will be able to drain the major segments, I
Why
think
not?
we
Why
we
not?
we definitely go in for the metallic stent. But type, I mean, the overall clinical experience with PTBD is much better than SEMS in type 4. But type 3, I mean, we need to take it's a patient to patient, and also the patients also feel comfortable in an endoscopic drainage vis-a-vis a PTBD drainage.
That's
So,
a very big issue because in PTBD, especially if it is done in stages and you've got a bag outside, very many patients actually they prefer opt for an endoscopic drainage when you discuss both the modalities. So I think that's a very big issue as far as PTBD is concerned. Technical success clinical is yes, but patient acceptability I think is more for the endoscopic drainage. And we also have been doing type 3 if it is after a good biliary roadmap and if I'm able to drain that particular system, why not? But Hmm. Dr. Garg, I know for type 3 and 4, I think he prefers PTBD straight away rather than going for endoscopies. Now, the radiology will speak for them, but I still place the slide. If we look at the scoring system where 8 and 9 is usually appropriate, it's the usual. For a distal, they find that endoscopic drainage is appropriate, but for a hilar block, they are keeping PTBD as appropriate. And of course, now they have come to the type of stents and how to drain 1 and 2. PTBD is always easier when they go from the left duct. And of course, in type 4, they are placing 2 stents. So this is the PTBD chart, the current status of how they follow. Uh, Now, to make matters more interesting, US guided biliary drainage has come in. Now, just for our understanding, I have used these cartoons to show where the stent is being placed. Commonest is this, where you do a hepatogastrostomy, where you actually are draining the left system. This is the tumor over here. Now, suppose if you have to drain the right system, you have to go through the duodenum, and then this is one where you place in a bridging stent and then do this. And this is a very common which we have been using in our center also, that you drain one system with your ERCP and the other you can take a help of the EOS or even a PTPT on this. So a combination of both the methods. Dr. Mathur, how I've not done this, how easy or difficult it is to put a bridging
honestly,
stent like this and then go?
yeah, and honestly, even I don't have too much
I
of
have not done this
experience.
at all, sir.
But if you look at, I mean, again, it depends upon the technical expertise of the
Sir,
center.
sir.
So I think they would be replacing these US guided biliary drainers with PTVD maybe, where they can drain do a bridging stent plus HGS.
Sir.
So that's a very good option. But again, we require a lot of technical expertise, and the learning graph is pretty steep in the.
Sir.
If the whatever the literature it says, it shows yeah, we have the literature.
Now, these are tabulation of 6 studies on US drainage for malignant hilar stricture. Now, if we just concentrate on this column, the technical success, we see all across the board, whichever way, either the right or the left system you have tried to drain, a very high clinical success, over 90%. Technical or clinical success. So US guided drainage is very good, but the caveat always remains high volume center, good skilled endoscopist where you have been doing US for quite some time. So those are, I think, prerequisites. Otherwise, there is no point in actually looking at this data. And this particular study was interesting where they have combined ERCP and EUS, and then they compared with the PTBD. And they found that it's almost for example, the technical success PTPT was 100%, though here they have written as 84%. I couldn't get the detailed text of this particular study. And clinical success, of course, was almost similar for both of them. Side effect wise, also PTPD is actually much less, except for patient acceptability. But my problem again, I come back to the question that when we do a PTBD, do we also do a tumor seeding? But I think this question will be invalid now because these patients are not going for a resection or a transplant. So, but anyway, so that issue always remains. So the bottom line is that US is induced guided biliary drainage is a viable option. A lot of success. Again, it depends a lot on what your unit is following. Most of the units for us, it is easy that whatever we can handle by ERCP type 1, type 2, and rest, I think it goes for a PTPD, something like that. But yes, as we all are getting proficient in our EOS techniques, definitely we'll be using more and more of this.
Yeah.
One solace we can draw is till date, we do not have any comparative trials between US and PTPD drainage for hilar obstruction. So advantages are obvious. It's a single step, but then this we have discussed the caveats. PTPD is comparable, but impaired quality of life, mainly because what we have discussed, what Dr. Mathu was saying, for the patient, what he prefers. So these are always there. But there is no direct trial. I think this is one area of study which is cut out for us. So the jury is still out. The ISG guidelines suggest that a decision about palliative drainage depends on the local expertise. It comes to that. And of course, this is what we said, that none of these modalities are actually substituting each other. Maybe if we combine, like we have shown ERCP and PTBD or ERCP and US guided for both the systems, that's how I think it will work. So if can we summarize it like this, that Bismuth 1 and 2, we go for ERCP, Bismuth 3 and 4, other modalities come in. And finally, if we leave aside the resectable one, this is the last aspect of our session today, the treatment strategies for unresectable cholangiocarcinoma. Well, it follows these steps. We have chemotherapy, we have targeted therapies, and we have got immunotherapies. Purposely, I have not gone into the details of this because I think it was too heavy when we tried to understand all this. It's always much better to go to the tumor board meetings, listen to them, and try to see how the algorithm is being built. Now, if you look at chemotherapy, this has been the usual line, but capecitabine has come in, which has now become the mainstay of our chemotherapies. As far as targeted therapies are concerned, like I have alluded to, fibroblast growth factor receptors and the HER2 receptors, the ERB2 receptors, earlier called as HER2 receptors, inhibitors. You have drugs and patients are being started on this. And of course, the immune checkpoint inhibitors, we are all aware from our HCC experience about the PD1, PD ligand 1 and cytotoxic T lymphocyte antibody 1, the inhibitors to this and how they manage. And of course, the latest kit, which has come in is the CAR T cell therapy. Now it has been there for, I didn't know that it has been used in cholangiocarcinoma also, CAR T cell therapy. So far it has been approved for, I think, leukemia patients. So CAR T cell therapy for cholangiocarcinoma. So I think technology is making a good thing. The question will always remain, like we had asked in HCC, that after this, what is the advantage you're getting? If you look at the studies for targeted and immunotherapy, what I was seeing is that mostly what you get is an advantage of 6 to 12 months or even less than that in most of the cases. So huge technology, huge expenses, and you're getting 6 months. Even then, it would be good if your quality of life remains okay. So the other question now comes in is your quality of life when the patient is undergoing all these therapies. Very, very difficult to answer, especially now since we do not have that much of data, long-term data. But I think these are the points which needs to be discussed with the patient in great, great detail. That, okay, if you are joining in all this, what do we expect? Because most of the patients enter this therapy scheme, मेरा ठीक हो जाएगा. Actually, नहीं ठीक होता है. You only gain couple of months. Even that is good. You can't pass a judgment on some family if they want 5 months more or a 6 months more. But then quality of life, that also becomes very important. That do I spend my 6 months in and out of hospital, or do I actually get to stay at home and have a reasonable quality of life? So these are questions I think which we need to discuss with our oncology colleagues also. But yes, these are the viable modalities. I've just summed up some of the studies which are here, and these again go back. If you look at intrahepatic cholangiocarcinomas, these are the 3 markers I've already discussed. Like CA breast, we started mentioning now cholangiocarcinoma, HER2 positive or negative. The drugs are there for them. So basically, since we are building up a molecular profile lab in our hospital, so these are the receptors that we will be looking into for targeted therapy for cholangiocarcinoma. This is my last slide. And so what we have done is that when I see a patient of cholangiocarcinoma, I first need to divide them into three. That is it localized, is it locally advanced, and metastatic. And how do I diagnose my cholangiocarcinoma? I think we have discussed in great detail. We need a good imaging modality, first of all, multiphasic CT. And if the biliary involvement is there, a good contrast MR. We build up the clinical problem. And EUS also helps us for resectability and staging. So now, if it is a localized disease, by localized I mean you have got a single or a focal disease. At the most, there will be portal node involvement and there is no vascular involvement. I would like to go for an R0 resection on this. And after resection, we find out whether the margins are free or not. If the margins are positive, or if my staging is becomes more than T2, I give post-surgery chemo. Capecitabine has come in a big way, or gemcitabine and cisplatin are the ones which have been used earlier. Now, if it is then this question, not a debate, which had come up that does liver transplant have got a better overall survival and recurrence rate as compared to R0 resection? Nobody knows the answer, but then nowadays, since we are expanding our liver transplant donor liver transplant indications, I think this also can join in. But of course, a lot depends on availability of organs. We still have such a shortage of organs, even for the cases which are well established. Doubt at least whether we can go for this or not. We come under locally advanced unresectable. That means beyond the portal nodes, the disease has spread. There is a good amount of vascular involvement, multifocal, type 4. Then it is unresectable, locally advanced. But among this also, we try to find out that can we downstage the disease and bring it back to R0 resection. Now for downstaging, we use neoadjuvant chemotherapy, and which is can be radiotherapy also, or sometimes like in HCC, we can use a loco-regional therapy and then see whether it is resectable or not. Transplant also comes in this, but then I'm not going into this, too complicated, and this is on case-based basis. Now, after downstaging, also you have resection, resectable or unresectable. If it is metastatic or finally it is unresectable, then you are left with chemotherapy, targeted therapy, immunotherapy. Sometimes we also give SBRTs in them. In R2 or a margin positive post-surgery chemo, we also have EBRTs and therapies coming into this, radiation therapies. So I think this is one tumor which indicates really a very multimodal treatment, where all elements and specialists come in, and each one of us, we are showing good results on whatever we are doing. So really, really, it will require a very long, at least a 10-year follow-up from big high volume centers to actually get a very clear-cut algorithm as to how to proceed. And this is where we come in a big way. Biliary drainage is there for all the stages. And of course, biliary drainage, we are good at it, but we also have raised a lot of questions, which we have discussed. That also is our responsibility to answer them well.
Thank you, Dr. Nandi.
Last key point, sir. It's a difficult tumor to diagnose and treat. Important to classify the tumor based on anatomy, growth pattern, histomorphology, and molecular profile. Multidisciplinary management is the key word. It gives us the best possible therapeutic option. Curative resection is possible in a minimal people. Liver transplant is, sorry for the spelling mistake, viable in some selected cases. Biliary drainage is important. And of course, there is an emerging success of targeted immunotherapy. And this is our unit at Amrita at Faridabad. And this is our hospital. Thank you very much for your patient hearing, sir.
Thank you so much, Dr. Nandi. It was an excellent talk, and we more or less comprehensively covered the intrahepatic and the hilar cholangiocarcinomas. We don't really have too much of questions, and I'm surprised actually. It's a compliment to your exhaustive coverage of both the pathologies. And it's good carry-home messages which we have given to the residents and to the consultant gastroenterologists. One is, yes, we need to diagnose them as early as possible, and we need to extensively investigate for the resectability of the disease. If possibly we are maybe rushing up too much early for the biliary drainage, and look for identify patients who can be resected. And the other to realize is it's a team approach. So the radiologists, the oncologists, oncosurgeons, and gastroenterologists should come up together in managing this disease. And regarding the biliary drainage, again, there are lots of ifs and buts, but sometimes the patient selection depends upon the entire scenario of the patient's preference, the local expertise, and what is the extent of disease which we have been able to assess. Very important radiological mapping, and also very important to identify the indications of biliary drainage. We don't need to drain all the patients, but only those who have developed significant cholangitis and pleuritis, or who are candidates for chemotherapy, radiotherapy to improve the quality of life. With that, I think we can conclude the session, and we don't have really too much of questions. So I think this is a great compliment to you. Thank you so much. And Nisha, can we close the session now? Dr. Nijaman is actually busy, so he's
Thanks,
not
sir.
with us.
Thank you, sir. I think we tried to raise some clinical, practical questions that we face day to day. And
Excellent discussion.
fine, but thank you, sir. Thank you so much. We leave the meeting, sir?
I think so. It's almost 1 o'clock.
Right, sir.